The big segment, the ultrasound abnormal findings on cardiac. So cardiac ultrasonography, very, very helpful, used very, very frequently. But I just want to go over some of the big picture things in terms of what are we. We're not doing cardiac echo on a cardiology level, but there's some things that we can make some decisions on, and I think it's gonna, just a good review of that.
Good.
So we'll look at pericardial effusion, similar to what we saw on the FAST exam, but this would be a non-traumatic pericardial effusion. We'll look at right ventricular dilatation and enlargement. This would be something that you'd think about in terms of large PE or pulmonary hypertension. And then the last one is going to be poor ventricular squeeze, basically a heart, such as a heart in CHF or one that's had a MI, having poor squeeze, not squeezing well, pump failure kind of deal.
Cool.
So pericardial effusion, this is pretty much, if you can remember the FAST exam when we're looking for pericardial effusion, the exact same thing. The only difference is this may be a pericardial effusion that's not from trauma or from bleeding. It can be from cancer or, basically
some autoimmune disease.
Disease, the list goes on. And usually that's a little bit slower, so it'll be more insidious, but it's pretty much the exact same thing. This is a subcostal long. Remember, this is your heart, right? This is the wall of your left ventricle. This is your descending aorta. This is your pericardium, right? The sac. Mm-hmm. It's a potential space, but there shouldn't be fluid in there. This is where your pericardium is here now. And you can see the heart, left ventricle, right ventricle, floating in this sac of fluid. That's a pericardial effusion. And if they're in tamponade or hemodynamically unstable, you need to do something about this in terms of getting that fluid out, setting them up to a higher level of care. But the view is pretty straightforward and very easy to do.
Yeah, just don't forget the descending aorta is going to be your guide. Fluid anterior to that, pericardial effusion, fluid posterior to that, or deeper on the ultrasound level is going to be more suggestive of a pleural effusion.
Yeah, perfect. So let's just outline that, right? This is the descending aorta here, right? And you can see it here. It is right there. And the pericardial effusion, it's pericardial because it's in front of it. If it was behind it, like in this potential space, which is lung, that would be a pleural effusion.
Cool.
Right? So cool. Perfect pearl. The next one is going to be right ventricular dilatation. So this is basically something that we're looking for. This is an apical 4-chamber view, which they review in the procedure part of how to do the ultrasound. And what you're looking for, just to kind of remind you, is this is your left ventricle, and this is your right ventricle, which is always usually smaller than the left ventricle in a normal heart, right? Left atrium, right atrium. This is normal, good contraction. What you're seeing on this abnormal is this is the right, and this is the left, and that's not normal. This is dilated and enlarged, and the biggest thing you worry about is, well, why is that? Is it obstructed because of a large PE, or is it obstructed because of pulmonary hypertension? This is mostly useful when I'm thinking, again, about PE, big PEs, and I'm going to be looking. There's other things that can cause dilatation of the right ventricle, but when I'm talking about emergency stuff, really that PE is what I'm going to be thinking about. It might give me a clue to go down that workup.
Yeah, for me, the way I remember it is the left side of the heart is the main pump, and that's what's pushing everything. The right side, it is pumping, but it's not as strong. And so the left side always has more muscle, so it should always be bigger than the right. And so when you actually see a right ventricular dilatation, when the right side looks the same, like almost symmetric as the left, something's not right. There are calculations about how you can measure the size of them, but for the purposes of just quick picture, like visual stimulus, like you see that the right side on the right side, the abnormal view, you can see the right ventricle looks almost the same as the left ventricle. Something's not right. And the other thing that you'll notice is in a normal heart on the left side, that septum, the intraventricular septum, is fairly still. It doesn't flop or bow to one side. On the right side, you see how it's flopping back and forth with every beat. That septal bowing is also suggestive that there is a lot of right-sided pressure. Just because of the amount of pressure in the right side, which is generally a low pressure system relative to the left.
Perfect. Yeah, it doesn't usually push it into the left, so that's a good pearl as well.
Cool.
So our last abnormal on the cardiac ultrasound, when we're talking about basic cardiac ultrasonography, is going to be the poor ventricular squeeze. And mostly what I'm looking for is how is the function of the muscles of the heart doing at pumping. And what I want you to notice on the normal, it's looping between a parasternal long and then it converts it to a parasternal short of the left ventricle. So this is the short. You can see this is the left ventricle and the musculature. That's some of the papillae, the musculature that helps hold the valves together, and this is the long. You can see you got nice left ventricle, nice squeeze. It's really closing up on itself and squeezing that blood out. I'm not trying to have you measure the EF like, oh yeah, this is 30 to 50, etc. We're looking for good, strong squeeze. You can see that these walls are closing on themselves and pumping appropriately.
Yep.
This is compared to your, this is a periapical 4-chamber, but you can see left ventricle, not a whole lot of pumpage going on there,
yeah,
right?
It looks pretty weak.
That valve is barely opening up. It's so backed up and not functioning very well. This person is going to be in cardiogenic shock or have really severe CHF, etc. This is the parasternal short. Same thing. This is the round part. This is your left ventricle with the musculature, and it's just barely doing anything in terms of squeezing that blood out of the left ventricle. So this would be poor ventricular squeeze. I'd be concerned for CHF, myocardial ischemia, etc. Basically pump failure.
Yeah, and I'll definitely reemphasize what you're saying, where this is not a quantitative measurement. This is an eyeball test, a qualitative one, where you say if you've seen enough and you practice enough to see what normal hearts look like, and if you just do it enough, you know that, oh yeah, that looks normal. And the one on the right, oh yeah, that definitely is not good. It's either good squeeze or bad squeeze. Keep it binary. Don't try to stratify it, because it's really useful in the setting of, for instance, like, oh, if this person may need, if I'm going to give more IV fluids, if you happen to be administering IV fluids, maybe you shouldn't give them that whole liter, because maybe they might not be able to process that very well because their pump is not working very well. And so it's those kind of considerations where it gives you a quick, literally within 5 seconds, a good idea of what their cardiac status is like.
Yeah, I use it a lot in shortness of breath patients or chest pain patients, just to kind of look and be like, okay, am I thinking about ACS, PE, CHF, just COPD, just stratifying the differences between those gives you an idea of how that works, and it just makes it a lot easier in terms of making diagnoses.
I'll say, just to wrap up this section, just again, from a clinical application standpoint, the cardiac ultrasound, I remember, because when I first started doing it, it's intimidating, because it's like, what are you looking at? What are the different structures? What am I supposed to be looking for? How am I applying it to clinical practice? You need to get over that and just start doing it, just to see what the normal baseline is. I think fast, the kidneys are a lot less intimidating for me, at least. But once you start doing the heart, you start noticing it's like, oh, whenever you have a shortness of breath patient, within less than 30 seconds, you can easily identify, do they have pericardial effusion? That's life-changing, life-saving.
Yep.
And then you can identify if they have, in the setting of a shortness of breath, if you're thinking about PE and it's high differential, that ultrasound is helping you to see that right ventricular strain. And then the poor ventricular squeeze too, in the setting of shortness of breath, it's like, oh yeah, clinically they kind of look like they're CHFE and maybe they're exacerbated. And you see this and it's like, oh yeah, that's definitely poor squeeze. And if they had no history of it, you just changed a lot of your direction of where the workup is supposed to go and make your disposition super easy.
Yeah, I mean, this is going to be obviously the abnormal stuff, but really if you kind of walk through the videos that go over how to do the actual exam for all these views, I think the nice part is it is straightforward, and it's just a matter of knowing what you're looking at and putting it to practice, and you get better and better and better as you go along.
There's no other way around it. You just got to practice on a lot of normal people, and you'll finally see what the distinction is between normal and abnormal, especially when it comes to heart, because it was really intimidating for me, but the more you do it, it's very easy kind of binary stuff. It's not like you're a formal ultrasonographer. You're just trying to answer some pretty obvious clinical questions.
Awesome.
Cool.
Well, thanks, Paul.
Nice.
That's it.
Thank you.
Crushed it.